Good morning, everyone, and welcome to this week's Department of Medicine Grand Rounds. Before we get started, a few housekeeping points. Please make sure your mics are muted during the presentation. Also, we kindly ask you to hold your questions and comments till the end, at which time you may unmute yourself or put your questions in the chat box. Lastly, the CME credit on the screen will be displayed at the beginning and at the end of the presentation. Today's speaker is Dr. Susan Pories. Dr. Pories is a renowned professor in the Division of Surgical Oncology at Rutgers, New Jersey Medical School. She earned her medical degree and completed her surgical residency at University of Vermont. This was followed by a surgical oncology research fellowship at the New England Deaconess Hospital and a medical education fellowship at Mount Auburn Hospital of Harvard Medical School. Dr. Pories currently serves as the Chief of Breast Surgery, Director of the Breast Center, Chair of the Breast Center Steering Committee, and Vice Chair of Surgery for Quality and Safety at Rutgers NGMS and the Cancer Institute of New Jersey University Hospital. In addition, Dr. Pories is the Governor of the American College of Surgeons Board of Governors, and in the past, she was appointed as the President of the Association of Women Surgeons. Throughout her academic career, she's been recognized multiple times, including 2 major awards from Harvard Medical School, including the A. Clifford Barger Excellency in Mentoring Award and the Shirley Driscoll Dean's Leadership Award for the enhancement of women's career. Please join us in welcoming Dr. Pories this morning.
Good morning, and thank you very much, Juan, for that kind introduction. It's a great pleasure and honor to meet with the Department of Medicine today. So we're going to talk about breast cancer screening. And I don't have any relevant financial relationships, sadly. Here is your number to text for CME credits. So today we'll talk about some of the current statistics, why we screen, how we can tailor screening to risk, and what the screening options are. So we'll start with some statistics. I probably don't have to tell this group how important breast cancer really is, not only here, but throughout the world. So this map shows on the top the most common cancers in men, which are primarily prostate and lung. And on the bottom, all the pink is breast. The orange is cervical. In 2022, there were over 2 million women diagnosed with breast cancer worldwide and 670,000 deaths from breast cancer globally. It's the most common cancer in women in 157 countries, and it actually occurs in every country in the world. These are the United States statistics from 2024. You can every year, the American Cancer Society puts out updated statistics, which are really terrific. And unfortunately, breast remains the #1 cancer in women and the second leading cause of death in women that's cancer related. So this is New Jersey. And you can see where I have the red circles, that's Essex County, where we are, and University Hospital. And the little red diamonds there, or the little red triangles, indicate where the rates are higher than the rest of the state. And unfortunately, in Essex County, we have an increasing trend of newly diagnosed breast cancers that's higher than most places in the state. That's on the left, and on the right, you can see that we have one of the highest rates for late stage breast cancer at presentation. And actually, the statistics I've put together for University Hospital over this past year, we currently have about 3 times the national average of women presenting with late stage disease, meaning stage 3 or even stage 4. That means people coming in often through the emergency room, young women, 40 years old with 4 kids at home, they already have metastatic disease. So that's really a tragedy and hopefully something that we can get a handle on and turn around. I just wanted to mention too that we're also one of the highest counties in the state in terms of obesity. Obesity is linked with breast cancer, and so it's something that we should be aware of. On the right, I have some numbers I pulled out of Slicer Dicer showing that the more obese the population is, the less screening we do, which is something we have to be aware of and kind of do better at. I wanted to say a few words about the African American population. There's an increased burden of breast cancer for this population. They tend to present with more advanced stages. They develop breast cancer at a younger age. They have a higher risk of aggressive cancers, such as triple negative cancers and inflammatory cancers. They also have a higher incidence of male breast cancers and a higher mortality. In fact, Black women are about 40% more likely to die of breast cancer than white women are. This is especially important here at University Hospital and in Newark because half of our population is Black. Not all are African Americans by birth. We also have a very large population of Africans who've emigrated here from Nigeria and Ghana, and also a lot of Haitian Americans, all of which come from Western Africa for the most part. And there is a very aggressive breast cancer genetically from that side of Africa. So that's part of what we're seeing here. These are statistics from New Jersey. The top line is the Black population, and these are incidents of late-stage breast cancer. So you can see here that Black women have the highest rate in New Jersey of presenting with late-stage breast cancer. There is evidence to show that if we could just get people screening with mammograms, and we really don't want to do biennial, we'd really like to do annual, but even biennial mammography would cut the breast cancer death rate by over half. So why do we screen? It's a huge expense. It's $13 billion a year. And we're screening a lot of women. That's why it's expensive. But why bother? Well, the reason is if we can catch breast cancer early, the statistics are much, much better in terms of survival and also the morbidity of treatment. So if we can catch a breast cancer when it's local, meaning it's in the breast only, the survival rate at 5 and 10 years is about 99%. In other words, it's pretty much curable. If it's regional, which means it's in the lymph nodes as well as the breast, survival is still about 86%. But if it's distant disease, if somebody comes in with, already has spread to their liver or their bones, survival drops way off to 29%. And in addition, as I mentioned, if the tumors are smaller and we don't have lymph node spread, then we have a much less morbid treatment course for most people. So this slide it goes back to when mammography was introduced in the 60s. And you can see that over time, as screening was introduced across the country, the death rate has continued to decrease. So today we can talk about screening by risk. I just want to point out these are the recommendations for women of average risk. And we'll talk about the difference between average risk and high risk in a moment. But one of the things I think that's really confusing for women and also for their doctors is all the different recommendations from the different professional organizations. I think these are starting to come a little bit more together, but women have been confused about whether they should start screening at age 40 or age 50, whether it should be every year or every other year. And some of the recommendations have been conflicting. Importantly, the U.S. Preventive Task Force recently changed their recommendations to start at age 40, and they're recommending biennial, but at least they've reduced the age from 50 to 40. Most of the other professional organizations do recommend a yearly screening, including the Society of Breast Surgeons, College of Radiology, the NCCN, the American College of Surgeons, NAPBC. So that's certainly what we recommend here, is starting at age 40 and every year having a mammogram. There is also some debate about when you should stop having mammograms. And basically, we recommend that if you're still functioning and living on your own and in good health, then you should continue to have a yearly mammogram rather than just stopping arbitrarily at age 74, especially because people live so much longer today than they used to. So who is high risk and how do we decide? So the risk factors for getting breast cancer, number one, is being a woman. Men do get breast cancer, but it's about 1,000 to 1. It's not that common in men. Having a family history, which we'll talk about more, a genetic mutation, getting older, and having extremely dense breasts. So we'll touch on each of these in more detail. And in addition to those factors, these things can also increase the risk. Having an abnormal breast cancer, a prior history of DCIS or breast cancer, and having chest radiation at a young age, for instance, like for Hodgkin's lymphoma. So these are some of the biopsies that can lead to an increased risk, or the biopsy results that indicate a woman has a higher risk: atypical ductal hyperplasia, lobular carcinoma in situ, prior history of ductal carcinoma in situ or invasive cancer, and as we mentioned, thoracic radiation. Increasing age also enters into this, as it does with most things. If you're in your 20s and you come in with a breast lump, it's about 1 in 20,000 risk that it's actually a cancer. By the time you're 50, it's 1 in 50. And the 1 in 8 that you hear about from the American Cancer Society is for women in their 80s. So the risk goes up as women age. So all the guidelines now, these are from the National Comprehensive Cancer Network, NCCN, which are updated quarterly, and they're available for free online to anybody. I highly recommend becoming acquainted with these and looking at them. They have great recommendations on not only treatment of cancer, but screening, and it's for all cancers. So it's worth registering for this and then checking it as you take care of patients. But essentially, women that are calculated to have a risk over 20% are considered high risk. So we come to these calculations by using models such as the Gale model, the Klaus model, BRCA Pro model, but primarily today, as I have it in red, most people are using the Tyrer-Cuzick model. It's a little bit complex, but it seems, and none of these are perfectly accurate, but that seems to be the best of them. So you can go to this website, IBIS, to put in your patient's factors and come up with the risk estimate. And more, the insurance companies are asking for the risk estimate when you go to book expensive testing like an MRI. So it only takes a few minutes to calculate this, and it'll give you a 5 or 10-year risk and also a lifetime risk. So I put up a QR code here that you can capture if you like, and this will take you to one of the risk models that you can play around with for yourself or your patients. pretty much we do get a good idea about whether there's a high-risk family history just by looking at the patient's family history, building a family tree, which you can do in Epic if you'd like. But essentially, these are the red flags you want to look for. Were the cancers diagnosed early, meaning less than age 50? Were there any ovarian or fallopian tube cancers in the family? Any bilateral cancers, male breast cancer, Ashkenazi Jewish ancestry, a family member with a known mutation, any triple negative breast cancers, or again, cancer like DCIS at a young age. We do have a full-time genetics counselor now who's just terrific. And if you send a patient for genetics evaluation, essentially she's going to take a 3-generation or 4-generation family history. We always include the age diagnoses. She will then explain to the patient the criteria for genetic testing and then talks about what a positive test would mean, what a negative test would mean, what a variant of uncertain significance is. They discuss the pros and cons of testing and whether insurance will cover it or not. The cost has come down significantly. So if a patient is interested and doesn't want to go through their insurance or they don't have insurance, it can be paid for out of pocket for as little as $250. Then the second visit is to go over test results, the implications of those, and talk about prevention, surveillance, in some cases prophylactic surgery if it's appropriate, and then the importance of sharing genetic test results if they're positive and autosomal dominant, such as BRCA1 or 2, with relatives that could be affected, and surveillance recommendations. So the surveillance recommendations for high-risk patients are a little more intensive than what we do with people of average risk. We usually recommend that these patients have alternating imaging every 6 months. So they would get a mammogram once a year and an MRI once a year, but they would alternate every 6 months. These patients can consider chemoprevention with tamoxifen or aromatase inhibitor, depending on their age. That can cut the risk of developing invasive cancer by 50% or even more. And then lifestyle changes can be discussed, such as weight management, diet recommendations, decreasing alcohol, and activity, exercise. Again, for women with hereditary breast ovarian syndrome, very similar recommendations, except in this population, the BRCA1 and 2 patients, we also can have a discussion about prophylactic surgery. Both a bilateral salpingo-oophorectomy and mastectomy can markedly reduce their risk of cancer. Nothing is 100%, as you know, in medicine, but it can reduce the risk by 90 to 95%. I just wanted to say a quick word about transgender individuals and how we screen them. We don't have very much in the way of specific transgender screening recommendations. So for the most part, we do follow the guidelines for cisgender individuals, and it's based on what organs remain in situ. In other words, if it's a man who's had top surgery and they don't have much, if somebody's had top surgery and doesn't have much breast tissue, they're not going to be able to have mammograms, but they still might have enough breast tissue that they would be at risk. And so they should probably be followed carefully with examinations. So it has to be tailored to the individual. So I wanted to talk a little bit about breast imaging. First of all, the report that you get back from the radiologist follows a very specific structure. First, you'll have the indication for the exam, whether it's screening or a lump or pain, whatever it happens to be. They'll describe the breast composition, the density. Then they'll highlight the important findings. Importantly, they compare these to previous examinations, and then they make an assessment and a recommendation for management. The comparison to previous examinations is very important. As with all x-rays, we always want to look at the prior films in comparison to the current films. I always say it's like looking at your kids' school pictures. You can't really tell how much they've changed until you look at their school picture from 2 years ago when they didn't have any teeth and now they have teeth. It's the same thing as with the mammogram. You may not notice a change because they can be subtle unless you look backwards. We do use a special reporting system for mammograms, which is called BIRADS, Breast Imaging Reporting and Data System. This is used worldwide. It's like a worldwide shorthand. So if you see somebody from France or Italy, their mammograms will also have a BIRADS reading. So BIRADS 0 means that the radiologist needs more information. Either we didn't get the prior films, it wasn't a good quality mammogram, has to be repeated for technical reasons, or there's something that they're worried about and they need more films. BIRADS 1 and 2 are essentially negative. A BIRADS 3 is pretty much a follow-up in 6 months for most cases. They don't think it's a malignancy or anything serious, but they want to take another look in 6 months. BIRADS 4 is recommendation of a biopsy. So these people will need to have a consult and get a biopsy done. And BIRADS 5 means that it looks like it's probably a cancer. And if the biopsy comes out benign, when the mammogram looks this worrisome, then may need to have a surgical consultation for an excisional biopsy. And then BIRADS 6 is a known cancer. So these are the standard images that we get on every mammogram: the medial lateral oblique, or MLO, and the cranial caudal, or the CC view. And you'll always see these labels on the films. What they tell you is the way that the beam is traveling through the breast. So cranial caudal is when the breast is compressed and the beam goes from top down, and the medial lateral oblique means that the beam goes from the medial side to the lateral side of the breast. Now, today we're doing primarily digital breast tomosynthesis, which is essentially like a little CAT scan of the breast. The patient isn't really aware of it because we still squeeze the breast in 2 directions, but the tube moves while the patient's in compression and takes multiple images, like little slices of the breast tissue. And this allows the radiologist to see lesions, such as circled here, that would otherwise be lost in the breast tissue. So this has considerably improved, maybe about by 20%, the diagnosis of breast cancer. And then we do offer this at university, and most places have now gone to this tomosynthesis or 3-dimensional mammograms. I want to say a word about dense breast because there's now a dense breast notification law that's nationwide. It started in Connecticut, went through about 38 states, and now it's a federal law that all mammography facilities must provide patients with notification of their breast density. The federal law is basically dense or not dense, but most radiologists do have 4 categories that they describe, either fatty breast or no density, 25 to 50% density, which is still considered not dense, heterogeneously dense, or extremely dense. And so some places do label these as A, B, C, and D, or they use this verbiage that I've outlined here. So we do have to inform people about this, and we have to tell them that they need to discuss it with their doctors and consider other screening. The problem is that the insurance companies don't necessarily cover all the additional screening. And you can see here, this is the most up-to-date map of which states require insurance to cover additional screening and which ones don't. Here in New Jersey, I believe that we do have coverage for additional screening, but you can see it's sort of spotty. And so depending where you end up practicing, this can be a little bit of an issue. So what are the things that the radiologist is looking for on the mammogram? You'll see in the report words like asymmetry, mass, calcifications, or distortion. Essentially, the calcifications look like little spots on the mammogram, and distortion, asymmetries, and masses, we worry that those are tumors. So we sort these out by doing additional imaging. First of all, we use ultrasound a lot because ultrasound can help us tell the difference between a lump that's filled with fluid, it's just a cyst, which is not dangerous, or if it's solid and therefore it could be either benign or malignant. I just want to point out here the second image down, well, the first image on the top is a cyst. You see how it's completely black. And for ultrasound, black is always good. It means fluid. The second image down is sort of grayish, which tells us that it's solid. But you can see that the edge around it is pretty sharp. And that's probably a fibroadenoma, probably a benign growth. Also notice that it looks like an egg on its side. It's in line with the tissue lines. When we see something that looks like that, where it's wider than tall, it's almost always benign. Now, the ones down below look like cancers because they look like eggs on end where they're pushing through the tissue. So they're taller than wide, and that's much more suspicious. In addition, they notice that they all have very irregular edges, which is also a sign that they're probably malignancies. So ultrasound is one easy way to do supplemental screening. Another way we do supplemental screening, as we've mentioned, especially for high-risk populations or for very dense breasts, sometimes we will order MRIs. This is how the patient is positioned for an MRI with their breasts hanging down into a gentle compression and then going through the MRI machine. So you can see here on these very dense breasts on the left, the radiologist really can't see anything. And once they have the MRI done, you can see that because there's dye used, the gadolinium, the masses and enhancement will stand right out for the radiologist to make a diagnosis. And here's another example of something that you just can't see at all on the mammogram, but it pops right out on the MRI. Now, there is another, what we call a poor man's MRI, that's becoming more popular across the country, called contrast enhanced mammography, essentially using iodinated contrast with a mammogram. The problem with this is that you do have to have somebody to put in an IV, give them iodinated contrast, and then, of course, some people do have reactions to that. So this requires more staffing in a breast center than we currently have. And so we're not offering this at this time, but it might be something that we can offer in the future, depending on resources and staffing. But you can see here how the dye helps the lesion stand out in the breast. So this is promising for the future. So how do we work up an abnormality when we find one? The radiologist will ask for additional mammographic imaging, or what we call diagnostic imaging, as opposed to screening imaging, and the targeted ultrasound, as we've talked about. So I just want to show you some pictures of the kind of additional mammogram screening or imaging that we can do. One of the first things is what we call spot compression. And basically, what they'll do is push down with a little paddle over the part of the breast that has a suspicious finding, so that it sort of pushes the tissue apart. Because sometimes what will look like a mass is really just overlapping tissue. Once you compress it, the lesion goes away, and in fact, the patient is fine. So compression view is very useful. We also do a lot of what we call magnification views, so that we're just looking at one little part of the breast where we might have seen some calcifications or something else that looks suspicious, and we're getting a close-up view of that one area. Sometimes we do both, a spot and a magnification at once, so we can really get a close-up look at what's happening. If for larger breasts or for things that are in a funny position, sometimes the radiologist has to do rolled views, rolling the breast tissue a little bit to get a better look at it. They get exaggerated views to get a good look at the lateral tissue. If it's a larger person, we may have to do a separate cleavage view or other tangential views about the edges of the breast to make sure that what we're looking at isn't something that's really just in the skin. This shows you some of the calcifications that we're looking for. And I tell patients calcifications are a lot like freckles and moles on your skin. We all have them. And of course, we don't worry about every freckle or mole, and we don't take them all off and biopsy them either. We only take moles off when they start to bleed or grow, or they have an irregular edge, or they're a funny color, something like that, or they've changed. And the same thing with the breast. We all have some speckles and calcifications in our breast, but when they start to come together as a little group, or they have funny shapes or patterns, then they do bring our radar up that they're suspicious and a biopsy is triggered. So here you can see in the upper left where these are pretty much benign, they're scattered around. They don't look too worrisome, but as we go across and down on the lower edge, you can see these are big groups of calcifications. They're linear, so they're following the duct, they're branching, or they're pleomorphic, which means they're all different shapes and sizes. So these are things that worry us and where we would tell the patient we need to do a biopsy. Again, if we find a mass, that will also trigger a biopsy. I just want to mention these different supplemental screening modalities. Each have their own specificity. MRI and contrast enhanced mammography are probably the most specific. We do end up using ultrasound, I would say, most commonly, because it is cheaper, easier, more comfortable for the patient. But the predictive value of it is a little bit less than an MRI and again, the contrast enhanced mammography we don't offer at this point. So talking a little bit about how we do the biopsy once we tell a patient they need one. So we have a couple different ways to do biopsies. We try not to do surgical biopsies anymore. We try to do them all radiology directed because it's less risk for the patient. If they're not going to the OR, they're not getting anesthesia, they're not running the risk of big hematomas or infection. Those things can happen with a needle biopsy, but it's a lot less common. So this is really a safer way to start the process. And then when we do an operation, we're doing one smart operation instead of having to drag the patient to the OR twice. So this shows how we do a stereotactic biopsy. This would be for a lesion like the calcifications that we saw, where the lesion is not palpable and it doesn't show on ultrasound, it only shows on the mammogram. So this is a mammographic identification of the lesion while the patient's on the stereotactic table, and then doing the biopsy with this machine. So the breast hangs down through the opening, the mammogram plates compress the breast, the imaging is projected on the wall, the radiologist can dial the coordinates to where the lesion is seen, and then the needle is fired to take a biopsy. We can also do an ultrasound guided biopsy if it's a mass that's seen on ultrasound. And you can see here on the left, we always take a picture of the needle going through the lesion to document that the needle was in the right spot. Now, you have to take this with a little bit of grain of salt because these are two-dimensional images. The needle could be in front of or behind the lesion and still look like it's in the lesion. So if you don't get an answer coming back that makes sense, that may have happened. And that's when we would say it's discordant. We either have to rebiopsy or remove the area. And we can also do image-guided biopsies with MRI guidance as well. So this shows how that's performed. All the biopsies done today are core needle biopsies. We don't really do fine needle aspirates much anymore because they're not very accurate. So usually this needle is connected to a vacuum device, which sort of sucks the tissue into the needle to make sure that we get a good sample. And then we always take a picture of the samples that are obtained. So you can see here a picture documenting that calcifications are in the specimen. This is very important to make sure that you have gotten the right spot. And then the radiologist always leaves a clip, a little marker to show where they've been, because sometimes all the calcifications can be removed, or there may not be that many left. We do want to make sure we go back surgically exactly where the biopsy was done, and the clips helps us do that. So this shows the mammogram of a patient after they've had a biopsy and a clip has been placed. There are many different shapes and sizes of clips. They should be described in the report, especially because some people will have multiple biopsies. And when we go back surgically, we want to make sure we're getting the right spot. So that's always part of the report. And it's something we always double check when we go to the OR plan a surgical procedure. Now, we used to always do needle localization to find those lesions and take them out, but we've now started using seed localization. And you can see here the clip, which is the little circle, and then a seed, which is placed next to it to help us find this in the operating room. So the seed or the localizer can be several different types. There are radioactive systems, radar systems, and magnetic systems. So we've adopted here at UH a magnetic system, and these magnetic seeds are put in. They're basically just metal. There's no danger to the patient or anybody else. And they're just inserted a week or two before surgery. And they allow us to not only find the lesion, but to decouple the localization procedure from the surgery schedule so that the patient doesn't have to go have a procedure done before they go to the OR. It's done as an outpatient, and then on the day of surgery, they can come right into the operating room. Then you'll see on the right where we take a picture of the specimen after we remove it. We have a little imaging system right in the operating room, and we take a picture of that, and you can see the letters and the numbers so that it tells the pathologist exactly where that lesion is going to be and saves them considerable time in processing these specimens. And it also provides documentation in real time that we got the right spot out. So this is a picture of our new mammogram van where we hope to detect lesions earlier, get out into the community more. We have a lot of other ideas about how we might improve screening in the Newark community, and these are things that we're working on. I just want to point out we have a team now assembled for the breast service. Our other surgeons are pictured here, Dr. Benjamin and Dr. Hosseini, who've both joined us within the last year, and we're very excited to have them on board. And our nurse practitioner, Sonam Patel, PA Liz Del Cid. So we work together as a team. And from when I came a year and a half ago, breast clinic was 1 day a week. We now have access for patients 5 days a week. So if your patients need to be seen, we can get them in a timely fashion. So I'll stop here and see if you have any questions or anything that I can answer. And I thank you very much.
Dr. Pories, hi, good morning. It's Dr. Clapbolz here, and thank you for this wonderful presentation and discussion on breast cancer screening and approaches to the diagnostics around it. It's great to hear about all the things that have certainly gone on. A little bit sobering to hear about the what's still present in certainly New Jersey and in Essex County, where we are all practicing. I'll encourage people either to speak up or to put their question in the chat or to raise their hand. While we're waiting on that, lots of things to talk about. I just wanted to circle back on the genetic counseling. You mentioned now you have a genetic counselor, which is wonderful and great to hear. What is the recommendation about when people who are at risk should have genetic counseling or genetic screening? The implications, as you noted, can be quite, significant.
Right. So when you get a family history that you feel is concerning, then it's always worth, getting in touch with Julie and making the referral. She will come and she gets people right into the schedule. She's really fantastic. And then she will go over with the patient, like I said, the pros and cons of testing, how it's going to be paid for. And I think one of the things people worry about is insurance implications, because we do have the Genetic Act, the GINA Act, that protects people from being denied insurance, but it doesn't protect you from paying a higher rate. So if you have a strong family history and you're worried you could be positive and you're worried about insurance, then maybe you want to get that life insurance in place first and then get the testing. That's one option. Or to pay for it out of pocket as opposed to going through the insurance company, but certainly something that she can discuss with each person in detail. The other thing, it depends a little bit on what kind of testing it is as to when you would want to get it done. So, for certain, she does testing for everything, not just breast cancer. So as you know, for certain thyroid cancers, endocrine cancers, you would want to test those people even maybe as children. Whereas, if it's a breast situation, BRCA or something, you may want to wait until the woman is in her 20s to actually do the testing.
Thanks so much for that. I see we have a question from Dr. Kra.
Yeah, thank you so much for this wonderful talk. It's always good to go back to where it all starts as a medical oncologist in terms of screening and the workup, things that we kind of don't always think about. One question I had for you, I don't know how much data there might be, is that, we're always looking towards other screening modalities. And one of the hot areas of cancer prevention and screening is, either circulating cell DNA or cell-free DNA or different like biomarker tests. So do you envision a future where we're able to detect breast cancer either using blood tests in addition to mammography to help with, kind of identifying breast cancer subtypes? Or can you ever envision a world where there is like a cell-free DNA test and mammography is kind of used as an adjunct to that?
I think that's in our future, don't you? I mean, I think whether it's going to be a blood test or a urine test, I think that at some point in time we're going to have that to help us sort out, which mammograms, which people are high risk, and also which mammograms, which biopsies need more follow-ups. So I think between AI, that I didn't talk about much, but that's something that we're going to be incorporating more and more into screening. And also, like you say, biomarker screening, or what we're going to maybe call liquid biopsies, I think, is certainly in the future. I worked for many years with Marcia Moses in Boston, and I hope to, continue that collaboration. But she's been working on urinary biomarkers, and, her dream was always developing just a dipstick, that you could use at home, dipstick your urine, and then you could see if you needed further testing or not. We're not at that point yet, but I think it's coming.
Thank you. I see we have a question from Dr. Padilla, one of our pediatricians, asking, are there any differences in the chat here with screening and biopsy between an adolescent, not fully developed, versus an adult? I guess perhaps probably in high risk, very high risk patients, I suppose.
So we don't really screen teenagers except with exam. And I think that would be something the pediatricians would probably be doing for the most part. Generally, we don't see cancers and breast cancers in adolescents, although sometimes we will see fibroadenomas or phylloides tumors, or what we call juvenile fibroadenomas. So I think if the pediatrician or the patient themselves finds a lump in a teenager's breast, generally what we would do is just an ultrasound. We would not use a mammogram or an MRI in such a young person. Generally, an ultrasound will show us if it's just a cyst and we can drain it or just reassure them, or if it's a solid mass that may need to be removed. A lot of times, if we can just do the core biopsy and prove that it's benign, we'd rather not operate on young women because their breasts are still developing, and we don't want to impair their ability to breastfeed and the shape of their breast if we can avoid that.
Thanks so much. One of the I think sobering comments I think that you have made, and you showed data over a period of 10 years. I think involved from New Jersey, and the prevalence in different groups and African Americans being higher, really not been a change. And so the question becomes, what can we be doing differently what should we be doing more of really to try and really impact this? And I know Dr. Natali is also on. Dr. Natali, as I'm sure you well know, has been running out our SAVE grant for years, which really has been involved in bringing breast cancer screening and other screenings into the community. You know, where are those gaps? Why perhaps have we not made a stronger impact over time? And Dr. Pories, maybe you want to comment, and I see Dr. Natali is on, and she might have some complementary observations.
So one of the things that I've gotten interested in, and I would like to bring to Newark, I'm trying to write a grant to support this, is what's called preclinical navigation. And actually, this is being done in New York City by Kathy and Joseph at NYU. And essentially what they've done is they've built a system where they train navigators to go out into the community, whether it's beauty parlors, churches, health community centers, wherever they think they're going to find, you know, people that need educating. They educate them about the need for screening. They'll make appointments, which a lot of times I think we're already doing, but the difference is in her program, they accompany the patients in to get the mammogram. They pick them up, they bring them in, they stay with them when they have the mammogram. And then if they have to come back for additional views, for a biopsy, for surgery, they stick with them. It's a longitudinal relationship. And I think it's that warm hand holding experience that seems to make the difference. Our statistics are not as good as New York City, and she's covering a similar area demographically. She covers all of Harlem. And when I've spoken to her about what we're seeing here, she said she's just not seeing that rate of late presentation. Now, I think part of it too is because we have here a population, as I mentioned, of Nigerians and Ghanaians who have emigrated. In fact, over the last 20 years, we've had an 80% increase in that population in Newark. And Newark has one of the highest populations of African immigrants from Western Africa in the country. So we have a very unique population, and work from Lisa Newman also in New York City, studying those patterns of cancer migration around the world. She has shown that the cancers from Western Africa, as I mentioned, are some of the worst in the world. And she thinks this is tied, she's not the only one, but I think she's really brought to light that this may be tied to the Duffy gene, which is something that developed as a response to protect people from malaria, but it also changes the immune system and makes the people in Western Africa more susceptible to cancers. So that's sort of what I'm thinking about, is the preclinical navigation, but I'd love to hear what Dr. Natali thinks.
Thank you.
Thank you. So no, this is, we certainly have a great partnership with Susan and the team. The state in the cancer prevention program, interestingly, they're trying to tackle the situation with our African American communities because the rates are so high. It's not an issue of uninsurance, right? It's not lack of insurance per se. 90% of African Americans in New Jersey are insured. It's really more, I believe, a trust issue and a knowledge issue, and then we have that responsibility to educate. We have done much better with capturing the uninsured Black population through the program in the last few years, which has been, a real challenge in where to find them. But I think we've done better. Last year, with the program itself, we found 7 breast cancers in the 2024 cycle. It may sound like you said early on, Susan, not a lot, given that the number of people we need to screen, we got to screen over 1,000 people to get to those 7, right? But it's still worth doing. I think that with Dr. Osemi here and her interest in risk assessment, I think we have a great opportunity to do this, you know, in a more sort of like targeted approach in getting people through that risk assessment tool. So I really look forward to doing that with you. We have a lot of work to do for sure.
Well,
Yeah.
thanks
it's
very
great to
much.
see that partnership.
Yeah, thanks. I see Dr. Weiss has his hand up. Dr. Weiss, I know you obviously involved in cancer screening for a long period of time.
Yes, thank you very much for your talk. I've also been involved for several decades in following persons who've been enrolled in substance abuse treatment programs. And what we've recently shown, haven't yet published, but have informed the Department of Health, is that there's a deficit in breast cancer screening among women who were enrolled in drug treatment programs here in New Jersey. And of course, you then see repercussions of that with, as you described, in coming in more advanced stage. And we've suggested to the Department of Health they need to develop a new collaboration with DMOS, the department that deals with mental health, addiction, and substance abuse, to more aggressively promote screening. And then Melanie Diaz, who's our coordinator for VSX Passaic Wellness Coalition, is on the call. She helped conduct some mini focus groups with us recently in some of the drug treatment programs, and informally assessed with the women getting screening for breast cancer. And we were disappointed, but not surprised to discover that wasn't a priority of theirs. And so it's a never group that we need to reach out to in terms of improving our screening.
Yeah, thanks, Dr. Weiss.
Yeah, that's a great idea.
Thank you. I think we have time. Was raised in the chat. I think it's really important to make sure people know how to refer patients in for certain kinds of studies. But just before we get to that, interesting question about patients with breast implants. Any changes on recommendations for screening in those patients? Dr. Pories, I don't know if we lost you there.
No,
There you
we
are.
screen people with breast implants the same way, but they do get additional views. They get, sorry, I don't know if something with the network, but additional views. Essentially what you do is you roll the implant in and out of the view. So you have to do double the, are we frozen? You could hear me, right?
We're catching up to you, yes.
Okay. Yeah, so we just do additional views. You roll the implant in for one view and then you roll it out so that you can get a look at, the tissue without the implant. Sometimes we have to also do an MRI or an ultrasound if there's any concern that the implant might be ruptured.
Great, thank you. A couple of questions about referring patients in and where can we currently send patients for CT-guided mammo who have contraindications for MRI any other referral processes that are in place here that have perhaps been further strengthened over the last year or two?
Well, we have, I think I had stopped screening, but let me stop. Maybe that will help. Okay.
Thank you.
We do have, you can refer through the mammo department or through our nurse navigator. Again, we don't offer the contrast mammograms here. That might be something in the future. We're a little bit short-staffed right now in radiology, so hopefully over the next year or so, we'll be able to help build that department up and offer more screening there.
And any Epic specific referrals, since we're living in the Epic world?
We do have an Epic referral that we do with the emergency room, but I think I'm not the one that makes the referrals, so I think our navigator is the way to go with that, or to just call the mammo department.
So
Thank you.
let me just add to that,
Just
Mark, just
quick
as a
last
quick
comment,
thing.
thanks.
Because we've been trying very hard as part of our quality improvement process for JMC to change the referral process. So just to place the order approach. So there is a very well developed now, I would say, combined approach to this, where you can put in your referral for a mammogram as a screening mammogram, but automatically it will add a diagnostic, an ultrasound, and the referral into the same order set. So that by doing that, the one of the challenges of the cancer center is chasing after people when there's an abnormal mammogram, because then you need the primary care doctor usually is the one that has to do the referral. Then you need that ordering provider to now do an additional order. And so to avoid all of that, that is the process. And hopefully that can get people streamlined much faster in order to do that.
Great. Thanks so much for that. Very important for all of us in medicine, certainly. Dr. Pories, I want to thank you for this really wonderful talk and really informative for all, and for this great discussion we've been able to have with you about this. I want to thank everybody for joining this wonderful presentation today. I wish everybody a great rest of the day. Thanks so much.
Thank you very much.